Okay, thank you, Giorgio. So I just put here how looks the pipe on the Western patients in terms of driver mutations. And my colleagues, Dr. Novello and Masco, had already addressed the most potentially applied drugs to the most frequently found driver mutations in the clinic, ROS, ALK, and EFR. But there are some others that are still important. Maybe because they are not very frequent, but we got drugs, or potentially we will have it in the near future. Or there are some others, such as KRAS, where we don't have drug, but we have been doing some efforts trying to get it, even not very successfully. But it's a very important proportion of patients. So starting with HER-2, I think we possibly, most of us remember this first report by Dr. Capuccia about of a patient with a mutation on exon 20 of the HER2 genes. Before that, we were somehow investigating the role of HER2 treatments for patients with HER2 amplification, which is not very frequent but happens in lung cancer, or with HER2 overexpression. Actually, there is no data that HER2-directed therapy for those patients is working. But as you see in this case, you have a mutation, maybe those patients are responding to such a treatments. And indeed, at the present time, we know that happens in about 1 to 2% of the population with adenocarcinoma of the lung, most likely to happen in triple negative, ROS, ALK, and EFR negative patients, particularly in never smokers, more frequent in females, Asians, and so on. And the data from this European study retrospective is that when combined with chemotherapy, anti-HER2 treatments, particularly trastuzumab, you're getting a really nice response rate in the range of 20%. We got also data of tyrosine kinase inhibitors, HER2 inhibitors specifically. We got data from dacomotinib response rate about 12% on this phase 2 trial, and there is a similar trial with afatinib with a response rate of about 18%. So not great, but I would say you're getting some responses, and I think most of us will try to get that for our patients. Possibly also worth it to mention data is that trial, the neratinib, which is a reversible HER2 inhibitor, also EFR inhibitor, and when given with temsirolimus, at least in this trial, the data in terms of PFS and OS were somehow improved as compared to the monotherapy treatment alone with neratinib. So I think this is something we should take into account as well into the future. So altogether, you see that the number of patients, a number of studies are potentially possible for those patients. Response rates are not great, maybe in the range of 20% with TKIs, bit better if you put some temsirolimus and so on, and the possibility of combining with chemotherapy, particularly trastuzumab, is always there. There are some very nice data, preclinical data, suggesting that the new generation of anti-HER2 agents may be more active in this setting, even in the resistant disease setting, and that is the case for the TDMA1 drug, which is an anti-drug conjugate, as you know, that is now being used in breast cancer. And indeed, there are some trials ongoing, including, and I think, an ETOP trial that is coming up. The second subset of patients is MET mutant non-small cell lung cancer. MET mutant non-small cell lung cancer. And I think you should remember that about 4 or 5% of the patients with MET, they also, with non-small cell lung cancer, they also got MET amplification. Less frequent, and more recently, it's been discovered that about 2% of the patients do have MET mutation on the exon 14. When that happens, actually, there is a proportion of the protein which is important for the degradation, because it's where the ubiquitin ligase is actually binding to the protein. So you have in this mutation, this portion of the protein is lacking, and therefore the protein is not degraded, so which means you're getting more and more functioning protein into the cell. So the signaling is overexpressed, I would say. So how often that happens is about 1 to 4%. That happens not only in never smokers, as most of those driver alterations, but also in smokers, half of the cases, and happen not only in young population, very often happen in older population as well. So we should take that into account, and also histology is not restricted, I would say, to adenocarcinomas happening in other diseases. It's still relevant to say that a number of those patients do have amplification at the same time, but some other cases have amplification of the gene through amplification, which is defined on different ways depending on the different groups, and it happens in about 4% of the cases as well. And in some cases you get amplification plus mutation, in some cases you get only amplification. You remember the data with crizotinib, you have true amplification, particularly high MET amplification, as defined by the group of Colorado or some other groups. In that case, you're very likely to respond to a c-MET inhibitor, and there are data not only with a crizotinib, but some other data upcoming with cabozantinib and so on. More data are actually upcoming with c-MET inhibitors in the case of exon 14 mutation. You remember the initial reports, not only with crizotinib, but also cabozantinib, as you see here, but also now, very recently, we have seen the update on the profile 1001 trial with crizotinib on that very population of patients, with response rates in the range of 40%, and actually median duration of the response of about 9 months. So the typical type of response you are getting on a driver disease. Response rate in the range of 40 to 60%, median duration of the response of about 9 to 12 months. Okay, so this is the graph of the duration of the responses. Okay. The third group of subset of patients I'd like to talk is BRAF mutated non-small cell lung cancer. And of course, KRAS dysregulated signaling is the most frequent unregulated pathway in lung cancer. And that happened in about 2% of the cases because of specific mutations on the BRAF gene. That happened in a number of exons, particularly exon 11, exon 15, and that happened not only in smokers, half of the cases, never smoker, the other half. In half of the cases, mutation is actually on exon 15, on the very specific spot of the B600E, that you know this is a very sensitive mutation in the case of melanoma to BRAF inhibitors, and particularly to BRAF plus MEK inhibitors. In that case, this is the most frequent one, about 55% of the cases being the V600E mutation. There are now data with BRAF inhibitors, bemurafenib, but also dabrafenib. Response rate, both agents very similar, in the range of 30 to 40%, as we say, the typical numbers, and median durations of progression, time to progression is about 6 to 7 months. There are now some more data. You know the work by Dr. Planchard and colleagues, combining BRAF inhibitor plus MEK inhibitors, as is being shown in melanoma, which is a more effective way to inhibit the pathway, and also you're decreasing somehow toxicity, particularly the development of squamous cell carcinoma of the skin. In that case, response rate is improving somehow, particularly the disease control rate, response rate more than 60%, disease control rate about 90%, and of course, median PFS close to 10 months, which I think are numbers really interesting. And actually, that very combination is now approved by the European Medicament Agency, and possibly we will have the possibility to prescribe into the near future in most of our European countries, and I think it's something that we should offer to our patients in case of we have found it. The last subgroup of patients, as we said, is the KRAS mutant. This is a very frequently dysregulated pathway in lung cancer. In about 25% of the adenocarcinomas, we got a mutation. That is typically on exon 12, also frequent exon 13, codon 13, and less frequently in others like 63 or whatever. The most frequent one, the typical one, is on codon 12C. And that's happening in about 45% of the cases. And this is the typical mutation associated to tobacco smoking. Of course, this is different from the ones you find, for example, on never smokers, which is about 5% of the mutations in never smokers in KRAS. So the first thing to be said is that KRAS is important in that disease, but even we have the feeling for quite some time that this is associated with a very poor prognosis. The truth is that some patients with KRAS mutations do have a somehow benign evolution, and actually there is no clear data showing that those patients do have worse prognosis as compared to wild-type KRAS tumor. So I would say no clear data on prognosis for those patients, and the same is true. And the same is true for predicting the let's say the effect of chemotherapy, not only on the adjuvant setting but also in the late disease. The final thing is about how to treat KRAS patients. Then we have tested a number of strategies. I just put some here, and just to summarize then that try to inhibit the pathway downstream, BRAF inhibitor, MEK inhibitors, and so on, is not being very successful so far. There were some initial data with MEK inhibitors showing some responses, some activity, particularly in combination with chemo, but the truth is that now phase 3 trial had been negative, and here is the example of the phase 2 trial by Dr. Jan that was somehow positive in terms of PFS, not that much in terms of OS, but the final phase 3 trial was not positive at all. Importantly, I think considering the BRAF inhibition in this very pathway, there was a description some years ago by the group of Mariano Barbasif, which is actually the guy that discovered that very oncogene some 30 years ago. And they actually show us that if you abrogate genetically on a mouse model the CRAF gene, but not touching BRAF or ARAF, is the only way that you're actually hitting the KRAS pathway on a therapeutical way. The issue is that it's really difficult in the clinic to inhibit only CRAF, but not touching BRAF. It's really difficult to get the specific inhibitors. Indeed, some years ago, we thought that maybe with a drug such as sorafenib, that we know is a weak inhibitor of CRAF, we may do something. The truth is that we didn't. Sorafenib is not working in that very disease after some trials such as the Mission trial we have done. And the reason for that is because it's really difficult to get a proper inhibitor of CRAF in the clinic. There are a number of efforts now being done, but that is a difficult one. More likely to happen, at least based on the initial data of these two groups here, Lito and Patricelli, is that the codon G12C inhibitors The idea here is that you're inhibiting not the activated form of the KRAS here, but the inactive form when it's on the bound not to GTP but to GDP, so that you're actually sequestering the drug with a covalent inhibitor. So in the circle, or I would say on the circle of activation and deactivation of the KRAS, you're actually sequestering the drug when it's GDP bound, so that it's not able to convert anymore to GTP activated, right? So those covalent inhibitors are also being tested in the clinic right now, and we hope to see some result maybe at the ASCO this year. And as you see, on those cases, there are some clinical data suggesting, particularly in combination with EGFR inhibitors, monoclonal antibodies, they may be particularly active. The second issue that is very important here to analyze is another synthetic lethality potential for KRAS, which is the combined abrogation not only of the KRAS gene, as happened, activation of the KRAS gene, such as in the case of mutated KRAS. There are some models showing that you're able to abrogate genetically, on those cases, the CDK4 gene, you actually getting the cells into senescence. That happened at least in preclinical models. And that is being tried to be reproduced on KRAS lung cancer by inhibiting pharmacologically CDK4. And we now got into the clinic a number of them, such as abemaciclib, palbociclib, even the Novartis compound, and so on. As you see in those data with abemaciclib, you see that on KRAS mutants, you see that there is a clear activity for the drug abemaciclib, which is not happen actually in the case of KRAS wild-type cell lines. And I think this is quite remarkable. Indeed, on the phase 1 trial with this drug, there were a number of responses, particularly not somehow decrease in the tumor size, and those tend to happen most likely in mutant cases, which are the very dark blue as compared to light blues, which are the wild-type patients. So this is something that is being actually tested on a phase 3 trial, which is close to recruitment in the second-line setting, comparing erlotinib versus abemaciclib, and I think we will have the data in about a year or so. The last word I like to comment is about immunotherapy on those patients with KRAS mutation. We have many data suggesting that smokers are doing better, particularly KRAS mutants. Very often, as you see the forest plots of the phase 3 trials, those patients are doing better than the overall population. Very likely because the number of mutations, those type of tumor they got, is quite high. Secondly, important is you see the type of expression of PD-L1 is typically higher than, for example, in EGFR mutants. But there are some interesting data, actually, upcoming saying that within the KRAS mutants, depending on the co-mutations, actually, those tumors are behaving differently in terms of responding to anti-PD-1 agents. And there are some data suggesting, for example, that when you compare cases with KRAS mutation having co-mutation on RKV1, those tumors typically are immune desert, so there is no TILs, there is no CD8 infiltration, there is very little PD-L1 expression. On the contrary, you don't have LKB1 mutation, but you got P53 mutation, you're having a huge overexpression of PD-L1, and actually you're getting a lot of CD8 infiltration. And those data are actually showing, for example, on those data from the MD Anderson group, showing a clear increase actually on CD8 in the case CD8 and decrease of, let's say, other I would say, wrong cells, such as Tregs and so on, in the case of getting LKB. Indeed, the very same group have actually shown, in terms of responding to PD-L1 agent, this is very true. Look at that here. This is the overall population of KRAS mutants. In the case you're getting a KRAS mutation plus an LKB mutation, 100% of the patients are not responding, so best response is progression disease. In the case you're getting a KRAS mutation plus a p53 mutation, half of the patients or more actually responding, and I think that's very reasonable data based on the molecular and immune landscape you see on those tumors. So this is something very interesting, I would say, that we should possibly take into account in the very future. So just to finalize, the take-home message is we have to actually know what is on the guts of our tumors so that we are able to better treat our patients. So it's not only EFR, it's a number of mutations and a number of other aberrations, and possibly in the future, not only the molecular profile, but also the immune profile that will help us to better guide the treatment of our patients. That's all for today.